To all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our upcoming schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You'll have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done timely to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Our speaker tonight is Dr. Daryl Osbahr. He is the Chief of Orthopedic Surgery and Managing Partner for Rothman Orthopedic Institute, Florida. He earned his medical degree and his undergraduate degree from the University of North Carolina in Chapel Hill, North Carolina. He completed his orthopedic surgery residency at the Hospital for Special Surgery in New York City and his orthopedic sports medicine fellowship at the American Sports Medicine Institute in Birmingham, Alabama. He previously served as the Chief of Sports Medicine at Orlando Health, Fellowship Director for the Orlando Health Orthopedic Sports Medicine Fellowship, Research Director for Orlando Health Sports Medicine, Director of the Orlando Health Orthopedic Sports Medicine Residency Education in Orlando, Florida. In that role, he served as the Medical Director and Head Orthopedic Team Physician of the Orlando City Soccer Club, USA Baseball, Orlando SeaWolves, Arnold Palmer Invitational, and Seminole State College. In addition, he is a team physician or orthopedic consultant for the Washington Nationals, US Soccer, Professional Golf Association, the LPGA and Symetra Tour, WWE, Eastern Florida State College, and the Orlando Ballet. Within the region, Dr. Osbahr serves as the Medical Director or Orthopedic Consultant for the Sunshine State Athletic Conference, Florida Youth Soccer Association, Florida High School Athletic Association Football Championships, Sunshine State Athletic Conference Football Championships, and Mid-Florida Pop Warner Youth Football. He will be speaking about sports medicine, the role of the team physician. And I'll let you take it away.
So thank you so much, Michelle. I appreciate it. And so in hearing that, clearly I need to do a better job at home with my family. We'll talk about a little bit of balance in this. And I know in talking to Michelle, a lot of the people that are here and listening are athletic trainers. And so, you know, what I think can come from this a little bit is my perspective from a team physician about what it feels like in, you know, in the role that I serve as part of the medical team. And obviously for the people that aren't athletic trainers, a little bit about the importance of that dynamic. And so I have no relevant conflicts related to this presentation. I'm always looking for conflicts in a good way. So my sports philosophy began is that, you know, some people were made to be injured, the athlete, and some people were made to take care of the injured. And so I was just like a lot of people on this webinar, you know, very much was an athlete growing up and had some injuries, and those injuries kind of you know, took care of me and my sports career, and had to learn another way to kind of funnel my passions. And so certainly at that time I didn't know sports medicine was available, but certainly over time I learned that. And so, you know, initially it was taking care of these athletes, and these were a couple athletes I took care of at the same time, and learning that my role might be better in a apron-led, you know, providing sports medicine care to the athlete instead. And so this is the team physician world, as a lot of people know on this call, is, right next to me on my right, the left in the screen was Rick Guter, the women's team athletic trainer, and then one of the PAs from Duke University was a PA-ATC and provided care for them as well. And so often this is exactly where you want to be, right? Want to be on my high knee getting a sacral decubitus ulcer and not doing too much during the games, except hopefully cheering on the team very quietly. But very, very quickly, this can be how your world changes. And so we can see here, looking at the left leg's not supposed to bend like that. And so you can go very quickly to being prepared to be able to deal with an injury on the field. And in this certain circumstance, what you realize is every situation is a little bit different. This was a game between two international teams that I was covering, and you have really no capabilities of understanding as you're providing care for the venue about who are the team positions even on the sideline. So making sure you understand your role and not knowing what how they are going to handle this. And so at the time, the team positions hadn't handled a lot of these injuries, so it was a very unique time for us to be able to kind of come into action, and they elicited our support in a non-egotistical way to be able to help out as much as we could. In getting this athlete from the field after a open tib fib fracture to the OR within 2 hours. And so that's obviously a very important thing. And when you're sitting there on the bench, you need to have all those phone numbers in your hands to be able to make sure you can make that happen. And then sometimes it goes like this. This was when we were taking care of the Orlando Predators. Not the Orlando Predators, excuse me, the Orlando Apollos. And you can see one player had a potential spine injury while hitting another player as the quarterback stepped up in the pocket and they hit each other. And so what I'm most proud of in this picture is everybody is very much focused on the athletes. A lot of times you'll see that when you review the film and the pictures, a lot of the people will be looking to other people to help. And so it's very important to stay tuned when you're on a field that you're being watched. And so you want to make sure your eyes are where they need to be and you're eliciting help from the people around you to go get the help you need. But you can't have everybody looking away from the athlete. And so when it comes down to the sports medicine team, in my eyes, it's not just the primary medical team, which involves the physician, like the primary care sports medicine physician and the surgeon, but also the athletic trainer, the therapist, the fitness coach, the nutritionists, the massage therapists, but also what else do you need to be successful? And so providing sports medicine isn't just related to the player itself, but it's the players and families. And so I have a 10-page list of over 50 consultants that hopefully believe in the same level of accessibility that I do to provide the same level of care, because I've probably been woken up more nights by player family issues than actually player issues. And also your non-physician consultants. These are just a couple, neuropsychologists, chiropractors, and sports psychologists and such, because everybody is very important in a non-egotistical way to be able to provide that care. And just this picture alone, we have physical therapists, athletic trainers, we have orthopedic surgeon, neurosurgeon, fellows, primary care sports medicine physicians that are all involved in that care. Now, the keys to success, and I'll put these in order as opposed to what they're up there. Most people will think ability is the key to success. To me, it's availability. You got to answer your phone. Affability, you got to be nice. And then if you answer your phone and you're nice, then maybe you'll have a chance to show that your ability is actually fairly good. And over time, that will be found out if you're not, if none of your players get back to play. And also it's our teams that, and Michelle, Dr. Henney has this as well, is we're only as good as the people that we work with or people around us. And so my key in my offices, in my operating room, is I make it very important to all our staffs to understand there are patients, not just mine. I want them to care about and be involved in the level of care. And so if we have athletic trainers that we deal with, I realize that if I don't have a good staff that works with me in the offices, then they're not going to be very accessible to be able to work with the athletic trainer successfully to make sure we're getting athletes in. And so it's so important to make sure that connection is well. And also it's important from my perspective to be willing to hear feedback, because oftentimes a lot of people in my seat won't necessarily know when it's a struggle to get into the offices. So I try to work really hard to make sure that our athletic trainers that we work with, or our physical therapists, or our medical doctors have a great opportunity to get people in, get them in efficiently and effectively. So, I'll go into a little bit of a history lesson here for a lot of people on the call that might not even know, but the early years of sports medicine were interesting. really trainers, and I hate using that term, but really it was trainers in the beginning. They were team employees, they were jack of all trades, the go-to person to treat the injured and sick player, but they really had very little medical training. And the goal was just to keep players on the field, whatever it took. You used to see players in bandages all the time and everything. Just put them back out there as quickly as you can and make them deal with whatever injuries they have, because the team was the priority, not the individual player. And so in that time, when you looked at physicians, surgeons were really not involved in the care at all. Medical doctors were actually at some points opposed to even athletic activity because it was bad for the heart. And so this is interesting. From a New York physician in the late 1800s, they were quoting the ill effects of the damaged heart after a former cyclist died. And it was very interesting to read this quote, but that finally the heart had enlarged through cycling turned on him after sedentary years as a bookkeeper. And that weakened organ began demanding beer, then cigars, but in the end, even these stimulants proved inadequate. So unfortunately for all of us on this call, we now know that cigars and beers are not necessarily good for the heart, and certainly athletics is much better. But we also have to balance this out with overuse has become an issue in the past, and how do we keep our players on the field and healthy? And so what's the modern day look like? So now it's no longer just a jack of all trades, trainer per se. It's a team employee that's still a jack of all trades. And so, I know that this quote has been given by my mentor, and I humbly believe it, that the athletic trainer is the glue that keeps the locker room and the care for the player together. And it's so important, because these athletic trainers are in a very difficult situation. And for all of you that are athletic trainers on this webinar, it's very hard as a team employee to be able to provide the level of care you want to provide in a safe environment where you feel like you can have an impact on that player's care, keep them healthy, and also balance the needs of the team and the coaches and the personalities of the team and the coaches. But we all know, and we all strive for the individual player should be the priority, not the team. And since the definition given by NATA about certified athletic trainers and the roles they have, all I can say is that I am nothing without every athletic trainer that I work with providing the level of care that they can for our athletes. And so it's so important to make sure that connection is important. In terms of team physicians, now the surgeons are much more involved. I talk about it all the time. How do you describe sports medicine from a surgeon perspective? And really, I'm an arthroscopist, but also I'm a team physician. That arthroscopist is my surgeon part. But this is where a lot of orthopedic surgeons, I think, don't necessarily look at it the right way, is that they don't want to deal with anything that's non-surgical or non-musculoskeletal. And so for me, it's much different. And what I try to leave upon our trainees is you have to leave the arthroscopy in the locker room, in the operating room. But my role as a team physician is very much being a medical team physician as well as an orthopedic team physician. Now, that said, I do not have anywhere of the knowledge that Dr. Henney does about the medical issues. And so I need to rely on people like that. But sometimes I'm in a locker room, or I'm on a sideline by myself. And I really take it personally to make sure I know as much as I possibly can. Or if I don't, I have no ego, and I make sure I find out the answer. But for a lot of teams we take care of, it's so important for me to have a primary care sports medicine physician and orthopedic sports medicine physician working together to provide that care. Because again, it should be athlete centric. And so for all of you that are athletic trainers, I really urge you to find people like Dr. Henney or orthopedic surgeons that work well together, because I think the care that you can provide for a team are phenomenal when you have it working as a team. So these are the ABCs I love to describe that I think about in providing care. I talked about the A's, the availability, the affability, and the ability. But also these B's and C's come into play as well when treating your athletes. And so balance. For me, the hardest part, I think, for everyone is finding balance in their life. And as a sports medicine physician or a healthcare professional, it's very hard to find balance, but you have to make this work for the long term. Behavior is important. You might be right, but it's more effective to be effective. It's more beneficial to be effective and right than just right. And you have to learn how to get across being right successfully to the general managers, the athletic trainers I work with, other physicians, and the players. And so it's very important to have the right behavior when you're interacting with them. You got to understand there's boundaries as well. Actually, I remember when I was in Brazil with our soccer team years ago, there was no athletic trainers that were there. There was a changeover in the staff, and I'll talk about that in a little bit. And with that, I was alone in Brazil with a international physical therapist, and no athletic trainers. And a lot of the players that were asking me to go out at night in Brazil. And so anybody on this webinar, that is not a good idea. So you got to figure out your boundaries, because the reality of the situation is that you have to get along with the players. You have to be seen as somebody who's vulnerable with them, but you also have to have a boundary. And so it's so important to keep that. And then there's the C's: compassion, communication, and covenant. And so compassion and communication makes sense, but the covenant is the contract. And so whether you're developing pro sports and you have a contract that's specific about the roles and goals, but I also like with our athletic trainers to review what my role is, what our primary care sports medicine's role is, what their role is on the team, how we work together. I have no ego, and I expect nobody in the locker rooms that I take care of to have egos. I like to get physical therapists and athletic trainers involved in a lot of the complex care we take care of, working as a team. If I don't do a surgery and it's not one that's in my wheelhouse, I make sure I get the right person to do the surgery. And so we need to have a deal and an agreement on how we provide the top level care and the best care we can for the athletes. And that doesn't matter to me if it's pro sports or if it's high school sports or rec sports. We need to do a great job of providing that care and hold ourselves accountable to do so. And also the thing is to remember, these athletes are patients and they're people. It's always hard to remember this. It's about taking this from the operating room into, a lot of these athletes have kids, they have families, and they go through a lot of these psychological effects of not being able to play. And we have to remember that at the end of the day, we have to be able to deal with these players and communicate effectively, because they are players and they are people. And so I love this slide. And I don't know if Dr. Henney has seen this before, but these are the sports medicine kind of team dynamics. And so, for Orlando City Soccer, this was Dr. Harrison Yeomans. I've worked with him for years. He is my equal, if not better, in a lot of things that I do and the teams I take care of. And so this is the medical team when I came to Orlando City in 2014. And so obviously communication is critical with the coaches, the management, the athletes, if they are parents, there are parents that are involved even in professional sports, agents and the media. And so this is what it looked like, and the communication that I had to develop with the general manager, the head coach, our primary care sports medicine, our soccer team, and our athletic trainer. And these are just a few of the people that were involved in the level of care that we need to have when we're taking care of these athletes. So the interesting part about this is any given year, communication can change. So I just want to take you through the 5 to 6 years that I worked with the soccer team. And so what we can see is, boom, the head athletic trainer changes. Then the general manager changes. Then the general manager goes to an interim general manager. Then the head coach changes, and he was an interim head coach. And then all of a sudden we got our final head coach. Now we thought we were fairly stable, but then we finally got our general manager. Then we went to another head coach with an interim status to another coach. So we think at this point we have our general manager, head coach, and head athletic trainer. Nope, at the end of the year we change our athletic trainer. Then the end of the next year we change our general manager, then a new head coach, and then a new head athletic trainer. And so why I love this slide is because I can communicate effectively with certain people, but as a sports medicine professional, it's important to learn that you need to change how you communicate based on the people you're dealing with to be successful. And so if I communicate with every single one of these people the same throughout those years, then our ability to be successful would have been much more diminished. I have to learn how to talk and speak the language of the people I'm working with and understand they all don't see things the same way I do. And so you have to be willing to be vulnerable in those situations and be moldable in those situations. And so for all the athletic trainers on the call, I know that all of us will believe in this, and I'm sure all of us have lived situations where we've had a great athletic trainer team physician relationship and some situations where we haven't. And so, that can be based on just personalities, just not necessarily mixing. But to me, it's so important to work together as a team. And if you are working together as a team, you have to work tirelessly to figure out how to do that. Because again, we're working on behalf of our athletes together and providing the level of care we need to provide. And there should be no elephants in the room when it comes down to this joint responsibility for teamwork amongst these two individuals, or three, especially with the two physicians I've been speaking about from primary care and orthopedic sports medicine perspective. And in fact, sometimes if you take care of international teams, you'll have a changeover. So this is a picture from USA Baseball, and when we were changing over from Mexico to Tokyo in 2019. We had 2 primary care sports medicine, 2 orthopedic sports medicine, athletic trainer, 2 performance specialists that were all changing over to make that transition from one country to another. And so it's so important to make sure that also as you do that, you don't come in there and butt heads with the other orthopedic surgeon or the other athletic trainer or the other physical therapists. You got to make sure you do that effectively. And so just let everybody know, because some people might not realize what it's taken to get to certain levels, and whether you're an athletic trainer or somebody else on this webinar, a little bit about kind of where I've been and how I became a team physician. And so I won't go through this because this is just a consensus statement for what a team physician is. The one thing I will point out with this is the sports medicine certificate of adequate qualification. And so for me, from a sports medicine elitist perspective, to me, I think this is important going forward for all physicians to have that want to take care of athletes. I think this is the extra board certification that's required if you do primary care sports medicine or orthopedic sports medicine, to say, this is what I do, this is who I am, and I do this at the highest level. And so for me, it's so important to make sure that that these are the type of people we get involved with our athletes. But the fact is we are a big country, and some areas of our country are underserved when it comes down to people that take care of sports medicine. So now what you're finding is the certificate of adequate qualification is really taking over in pro sports and a lot of high level Division I sports. But when you get down to Division III sports, even high school sports, you don't necessarily have people that do that. And it's important to have, in those situations, people that are passionate and are knowledge thinker, are thirsty for knowledge and how to take care of athletes. Because again, I think we'll all agree that athletes are different, and each sport is different as well. And so this is the long road I took to become a team physician. You'll notice some changes in the pictures I'll show, but I started off college at University of North Carolina at Chapel Hill, a great number of years of my life. I went to medical school. This is my high school sweetheart who I met in Florida. You know, I was excited at the beginning. We were both nice and tanned and ready for a long road of life. This is the residency. I did a 5-year residency in orthopedics. Most of the other subspecialties are 3, including family medicine, ER, internal medicine, physiatry, and pediatrics. Most sports medicine specialists are family medicine if they're primary care sports medicine, but especially ER and pediatrics have been picking up over the years. And then everybody usually does a sports medicine fellowship, and that's really where we talk about being sports medicine trained or fellowship trained. And after this, you're able to take the CAQ if you've done a sports medicine fellowship. Now, to be an orthopedic surgeon that it takes the CAQ, you have to do a sports medicine fellowship. And then you can see now my lifelong learning and my transition from a chief of sports medicine to a chair of a department has really caused a lot of gray hair to come in my hairline. So what's the interesting part about this road is that, and what I always talk to when I talk with people that are interested in this career, whether even people on the call are interested in potentially going back and becoming a physician or becoming a PA involved, it's important to live your life while you're doing it, because the journey is just as amazing as the end of the road or the destination per se. And so I was very thankful to have some great experiences along this way, including going to other countries for part of my training. So if we look at the team physician on the field, the medical management of the athlete is critical. And these are some kind of buzzwords that we look at to provide great quality care from a physician perspective. But also there's a lot of administrative and logistical duties. And if we look at Major League Soccer now, it's amazing. You know, our primary care sports medicine physician has become almost you know, within the Major League Soccer world, a very much administrative position. The amount of paperwork they have to fill out on concussion evaluation management, visiting team problems has been tremendous. And so now, especially with the legalities that go along with taking care of pro sports, it's so important to make sure that you are documenting everything. And so this has really become a big part of sports medicine, which hasn't been in the past. In the past, if you just showed up and provided care, then that was enough. Now we really think about the documentation of what we do. So on the field, the team physician, I always have to remember, and all of us have to remember, the athlete is our patient. HIPAA rules apply. Duty is to the patient and do no harm. We must prioritize the athlete, and this is regardless of pressure from the management, coaches, the team, the player, and the fans. And you need to really prioritize the athlete's interest for the preservation of health. And so one of my statements has always been, to do my job, I need to lose my job, and I need to be able to lose my job. And so I can't be concerned about what other people think. I have to do the right thing. And so really it comes down to Spike Lee and doing the right thing. Also, you got to remember on the field, I love this picture because you can see here I am sitting here in this position talking to one of my athletes, head athletic trainer, somebody with the camera here. We have this, picking up sound for ESPN at this point, and other people listening in. And so you got to always know you're on. And for everybody taking care of athletes, you're always on. You never know what somebody's going to hear or see that they don't like seeing. And so you always got to be thoughtful of that. Obviously, do the right thing and do the right thing for the athlete, but always be knowledgeable that perception is important. How about off the field? Well, there's challenges and rewards clearly. And so I remember my wife used to show me some of these pictures of me falling asleep all the times with my kids, especially early in my career, not necessarily balancing things as well as I could because there was a lot of time away. And sometimes it's exciting, but it's too much. You don't have any time to have a respite from what you do. There is a lot of pressure sometimes. These are pressured decisions when you deal with high profile athletes, but also in the high school and college, it can be pressured because their future may be at risk. And so you have a person that's starting a young career, and when I operate on those people, it's thoughtful of what their goals are and trying to help them achieve their goals. The challenge is also a unique practice environment. You're on call all the time, and I've answered telephone calls in front of the Eiffel Tower in other countries, and so you're on the front line of sports medicine, which is great, but also you have to provide the care in so many different environments can sometimes be challenging as well, because I always make the statement VIP level care isn't always great care. And so you have to learn to provide that quick and efficient care, but make sure that you don't lose anything from providing it, because always people want answers quickly. The biggest example I give is I'll see patients all the time that don't get simple x-rays, and you lose a lot of information when you don't get an x-ray and you just go to an MRI. And so it's important not to just go through the same steps. You got to make sure that you're really breaking it down to that initial information you need with a great history, great physical exam, initial x-rays, and if you need the MRI, get the right MRI, because you will certainly miss things if you skip steps, which tends to be part of the mantra for taking care of VIP athletes sometimes. Now, how about off the field? There can be rewards, right? If we can see here my son hanging out with Tiger Woods with his buddy. He was pretty cool that day for his friends. Alex Morgan getting a birthday card for my daughter. So what I've learned over time is if I do this effectively, I try to make my kids and my family part of what I do. Now, sometimes that can be challenging. Obviously, in the COVID world, that hasn't happened as much, but it can be exciting. And you got to make sure to have that balance well, where also your kids don't become prima donnas as well, which sometimes becomes the issue. But there's nothing better than getting somebody at the highest level of play back to the field successfully. And so that's an honor and a privilege. And so being part of that for me has been a huge reward. And that diversity in my unique practice environment, how I provide the care, has been phenomenal. And so I figured I'd go through a case presentation of an on-field injury. I do have permission from this athlete to share their story because it's been out in the press in the Major League Soccer world. But the surgical pictures and the clinical pictures aren't this athlete's, just to let everybody know. And so this is a 20-year-old male professional soccer player, attacking midfielder. He had a history of a right ACL surgery in 2015. Left knee injury while cutting, defending. That's a lot of times where you can have knee ligament injuries. Is the act of defending. Doesn't mean you're a defender, but the act of defending and felt the knee give way. Initial symptoms were mild, continued to play. The knee didn't feel right. Was having increasing pain and laid down on the field. On-field examination, which is critical. Again, you're being evaluated and followed on the field for what's happening. At this point, it's triage, as a lot of us know. So at this point, the triage was concerning and made the decision to remove the player from action, which was the right decision. Interesting in this scenario, every sport's a little bit different. And so depending on what type of athletic trainers we have on the call, taking care of soccer is different than football. And I know a lot of you guys know this, but in soccer, obviously with the no substitutions, athletic trainers are vital. Because you got to make spot decisions on the field, and obviously, if you're wrong and the player didn't have a significant injury, that can be hard too. But this player had injury consistent with an ACL injury. 2B, 1 is a little bit of translation, but an A is a good endpoint. So 2 is more translation, and B is a soft endpoint, which would be consistent with an ACL injury. And so for those that haven't seen a lot of MRIs, this is the patella. I'll show you this is a normal image. This is the patella, the femur, tibia. This is part of the PCL coming up, and this is a normal looking ACL right here. Well, notice you just have a sliver of fluid in the knee. On this side, you'll see a lot of fluid on the knee. And so when you have a young patient with an acute injury with a lot of fluid in the knee, that is a sign that you could have a meniscus tear, a patella dislocation, or a knee ligament injury. And so what we can see here is, if my cursor will work, here's a little bit of the ACL tissue coming up, ACL tissue coming down, but there's a lot of chaos going on in here, and that's consistent with a complete ACL tear. So the diagnosis with an ACL tear, now this is where the interesting part gets for somebody like me, if you're dealing with a pro athlete, is initially you'll have the media coming up asking everybody what the problem is. You know, I have to that night talk to the player, the athletic trainer, the general manager, the head coach, teammates that come up, International Soccer Association in this situation, as well as the agent. And so obviously it takes a lot of effort. And so what I always tell people, if you don't want to do sports medicine, again, if you don't want to answer the phone, you shouldn't do sports medicine. And if you don't want to talk on the phone, you probably shouldn't do sports medicine. So this, I'm going to go through an ACL surgery to let everybody know, and this is a pet peeve of mine, and Dr. Henney probably knows this, as I've said this several times. A lot of the layman's press talks about ACL repair. There is such a procedure as ACL repair, and I do them. That's when you repair the native ACL. But most 99.9% of ACL surgeries are ACL reconstructions, and a reconstruction is where you take graft somewhere else and make a new ACL. And so in this case, we're going to take the patella tendon, which is a piece of bone, center part of the tendon, a piece of bone, and this is what it looks like. And this is going to go in the femur, and this is in the tibia, and I fixate it on both sides. So you'll see bone coming down here to another piece of bone, and I fixate it on both sides. And so we'll go through this really quickly just to show. This is the footprint on the femoral side for the ACL right here. So what I'll do is put my guide in position in that spot. I'm using what's called a flip cutter, where I'll drill in, and you can see it's like a drill, and I'll flip this up. So I'm able to create in this case, a 10mm drill hole or a 9mm drill hole in this position. And so I'm bringing this up to create a good tunnel where I'm able to take away this extra bone. So I'm able to put this piece of bone into the tunnel successfully. Now I'm able to clean off some of the native ACL, but I love doing that because it shows I'm right in the center part of the ACL. And it's not confusing where to put the ACL if you keep some of those ACL fibers there. I'm looking up into the tunnel here, and you can see up into the tunnel, I'm going to pass a loop suture, and that's going to help me pass the graft. So I'm going to pass this down later in the case. You can see right there. And I basically grab that, and I bring it out one of the portals that I've made just to be able to pass the ACL later. Now what I'm going to see is this is where the ACL was here, and that's the PCL behind here. This is where I'm going to drill. So the ACL is going to go from here down to here. And I'm drilling on this tibial side right here, where I drill outside in. So you can drill also with a guide wire and what we call a reamer over that guide wire to drill a tunnel as well. And you're going to see me coming up into this as well, just to be able to drill past this point. And you can see right here, and I'm smoothing off the back part of the wall. And so I'm going to just fast forward this a little bit. This is where I pass the suture down. The button is going to be like this button over here on this right picture on the bottom. And I'm passing the graft up into the knee, and I'm just going to go forward a little bit. Now you can see that's the bone, and I'm passing this up into that tunnel, and I'm just going to go forward, and I'm helping push it a little bit just to be able to get it up in there well. And then you can see here's the new ACL right there. And that's me going into extension to make sure that the graft doesn't hit and I have enough room. So, and that's in full extension. So that's an ACL reconstruction type procedure. So this is where the journey just begins, and a lot of not journal back to the field, but journey back to the field. I just saw that, but the journey is long, and for me as a clinician and a orthopedic surgeon, I'm very dependent upon our athletic trainers and our physical therapists to provide this level of care in these postoperative phases to really get this athlete where they need to go. And for me, the most important part of this is not only understanding we're trying to get their motion and strength back, we're trying to prevent the next injury. What I always tell our athletes is the #1 predictor of performance is prevention of injuries. If you continue to get injured in your career is not going to be very long. So it's so important to get buy-in early on in this process to make sure that the athlete understands that even though they might feel like they can return to play, they need to make sure that they're able to do it successfully. And I've started to implement not only a return to play protocol where they need to pass certain criteria, but then a transition to play program where we'll increase what they do on the field. So for example, you'll do some sport specific drills to one-on-one, no contact, to one-on-one contact. Then you'll go into more of a practice type scenario, non-contact, full practice, where you're increasing the duration and intensity. And then you'll go into contact with trusted players before you get back on the field. Now that said, when you get back on the field, it's not playing 90 minutes, it's playing 30 minutes in the beginning and increasing the minutes slowly to make sure that the knee tolerates the level of intensity. And you're providing an environment where it's hopefully have a good transition to get the player back successfully. I think in the past, it used to be, if you had on a Biodex machine, 20% deficit compared to the contralateral side, at 6 months, you're back to play and you're put back on the field like any other player. And I think in this day and age, that's not enough. We got to make sure we're doing more to get players back and making sure psychologically they're back as well as physically. And so that's the emotions that go into it. I just mentioned the psychology of this. 50% of ACL reconstructions that don't get back, it's because of psychological issues. It is not because of just the physical. And so we don't do a great job of treating that. And so when you're trying to get this player back, you need to understand that they might have a ton of different emotions. You might get some players that are just going out of there like a bat out of hell and are just too amped up. And that's a problem as well. So you need to understand they can be excited, nervous, they feel pressure, sense of relief, fear of re-injury. You need to talk about these things and open up with the players to make sure that you're able to get a good understanding of where they are. And then how do you know when an athlete's truly back? That recovery, as I mentioned, is psychological and physical. And I love these pictures as we go through this, as we've seen the athlete transition through successful return to play. And we can see here his face after scoring his first goal doesn't look like he's very happy, does it? And then when we go into the second picture, we can see here that finally the arms are in soccer, the arms are starting to go out away from the body, but not necessarily a smile yet. And then finally, we can see here the smile is on the face in this bottom picture, where really that's the time that you know they're back. They're fully in, they're engaged, they're smiling, they're out on the field enjoying soccer again, because that isn't always day one. So in this player's successful story, it obviously helps to be able to have some success. And so this player was named runner-up for comeback play of the year, Kevin Molino, top 10 in goals after having a second ACL on opposite knee. And so, what we ask these players to do is pretty phenomenal. And so I wanted to show this little clip of when he came back into the MLS is back, the actual end of the year tournament for Major League Soccer for the MLS Cup is, and you can see what is required of a player to be successful and be able to play on this knee. So we'll just run through this. So you can see the player here. And so you can see there, the player pivoted on the same leg, rotated, kicked the ball in the air over their head to get it into the other side of the goal. And so, to be able to do that and have that reaction isn't the first day. And so they have to learn how to get back to that point. And that's, again, not day one after they're cleared back to play. And so what I'd like to do with the last two slides is give thank yous. And so thank you to my mentors. All these people have been instrumental. Dr. Andrews himself is like a father figure to me, as well as a mentor. And all these other people have been huge mentors of mine, and not mentors that have began and end as I've moved on in my career. I still call these people. I know Dr. Henney has had Dr. Dugas previously on one of these webinars. He's phenomenal and very much close, like a brother to me. So all these people have been fantastic to me, but also the reason I'm successful is because of my family. And so these people are crucial to my success and have allowed me the privilege of being able to provide care and learn some of these principles that hopefully I've kind of showed people some of the seat that I sit in a little bit, and how I feel going through these moments of providing care for athletes. The thing that I've learned is in my personal and professional life to be vulnerable with your athletes, be vulnerable with your staffs, and that ego is the biggest killer of culture. And so to me, when you're providing player-centric and patient-centric care, there should be no ego. We should all be working together as a team to get back our players and athletes, keeping them on their teams and getting back to their teams. So thank you to Dr. Henny and Releve to allowing me to kind of speak with you guys tonight. And I think now we'll be able to answer some questions if anybody has any questions. And here's my contact information with my office and my email too. Forgot that.
Awesome. Well, thank you so much. This was a great presentation and certainly does emphasize how it does. It's a lifestyle, it's a career. It's not just a career choice. It's certainly a lifestyle choice to get into sports medicine, like many of us are that are here today on this talk. So if you have any questions, you can put those into the question box, and I am happy to run through those.
Should I end the screen sharing, Michelle, at this time, or should I keep this up?
What I'll do is I'll go ahead and put up the future talks, and then I will change here, there. Okay, so Mary asks, how would you recommend an athletic trainer approach asking a team physician to be more active in the care of their athletes? For example, at the college level, NAIA.
At the college level, what was the last part?
NAIA.
Okay. That's a great question. Let me just start out by saying this. If you don't feel like you have the ability to have a physician that's engaged where you can be honest with them, then that's a bad sign. You know, I think every physician should be able to hear feedback from our athletic trainers and have that same relationship, you know, back and forth. I learned early in my career. Let me tell you a quick story. I can remember I was on a phone call. I don't know if I've told Dr. Henny this. I was on a phone call early in my career with an athletic trainer. I was getting very frustrated. And I hung up the telephone, or thought I hung up the telephone, and was on the other phone when somebody else called. And I was just like, you know, it's killing me. I'm trying to explain what we have to do, working in a not egotistical way. And instead of having the gumption at that time to be honest with that person and call them initially, I learned very much at that point that that's a conversation I should have had with that person first before it got to that point. And so I think for everybody on this call, if you don't feel like you have the ability to communicate with somebody effectively to provide better care for your athletes, that's a problem. And I think you have to create that, and you have to test it. And certainly being very open and being gentle at first with how you say it to make sure that you're able to at least test it out. But every athletic trainer, it's a privilege for, I know, Dr. Henny, myself, and others to be able to take care of athletes. And so we should be able to provide a safe environment for you guys to voice your concerns if we're not doing things at the level that you guys desire. Because as I mentioned, that communication is crucial. I don't know if I answered that well in terms of giving you the exact way, but hopefully I would try your best to make sure you start the conversation as soon as possible. And like I said, if they're not willing to be somebody who can be there for you in that way, then that is a concern, because you're hurting athletes by not having a team physician engaged that way.
Okay, our next question comes from looks like there's a partial question here. Nadine asks if you had talked about meniscus repair along with ACL reconstruction.
So actually, one of the talks we were talking about giving was meniscus repair tonight. I am in part of the Save the Meniscus Repair Society, and one of the things that upsets me the most is young athletes that have their meniscus trimmed out. And so it is a passion of mine. 99.9% of the time, if I'm going in there on ACL surgery, I'm repairing somebody's meniscus. You know, that is the best time and the best opportunity to get meniscus to heal. The only caveat to that is if you have a chronic ACL injury where somebody's torn meniscus over time and it's just unrepairable. But I would rather have a failed meniscus repair and not have ego when I have to go back in the knee and fix it out than ever that I caused somebody to be more likely to get arthritis because I didn't even give it a try. And so I am very aggressive on repairing meniscus. And the number of times I did 150 ACLs last year, and the number of times I've had to go back in on people's knees to trim out meniscus is extremely low when I've been even valiant in trying to repair. So I'm a big fan of repair. I think everybody should be trying to repair. There are elite athletes that sometimes if they have one that is not able, that choose to have a partial meniscectomy. In those situations, I go through the options with them and make sure informed consent is done. And I try to tell them as much as possible the risks and benefits to the decision they're making, because the only thing I can't solve for is meniscus repairs is anywhere between 5 to 6 months out of play, while partial meniscectomy is 6 to 8 weeks out of play. And so you don't want to waste somebody's 5 to 6 months, right, if they aren't in for it. And so it's their decision, but you have to give informed consent. And so, but it is something near and dear to my heart. Why? Because I do meniscus transplants. And so I'm the person that has to deal with a lot of times problems when people have had meniscus trimmed out without even giving it a shot. I'll get off my soapbox now.
Well, before you do, Nadine had a follow-up question asking about how does performing a meniscus repair impact your return to play planning and scheduling?
Well, number one, every meniscus tear is different, and every meniscus tear is different. And so there are some meniscus tears that are more stable than others. And so if you have let's say this is the meniscus, the C, and you have a Longstrom tear that's in the red zone where it can heal, and when you put weight on it, it compacts the meniscus tear. Sometimes you can put weight on it. The other side, if you have a radial tear that goes like this, and you put load on that, you're going to separate those meniscal fragments. So you have to really go non-weight bearing. And so what I do in my operative reports, as well as when I have my physical therapy protocols, I try to give what the tear looks like, and that's why I treat it. And we also try to communicate with as many athletic trainers. I have a physician assistant who's a PA-ATC, Riley Williams. And so anybody that I've dealt with probably on this call has met him at some point or talked with him. We work really hard to make sure we're talking with everybody to make sure that we give those little pieces of details to the why. And so for me, it really comes down to every meniscus tear is different. The more stable the tear, the more you can bear weight on it. The more unstable the tear, the more you can't. The people that get stiff are young females with meniscus repairs. And so there is, if you can't bear weight on it early, there are downsides that you're more likely to get stiff. But I'd rather somebody that gets stiff that I have to go back in there at 3 months and lice adhesions and with a healed meniscus tear that I've helped their long-term health of their knee than not repair meniscus just because it made it easy and they were less likely to get stiff. So, again, my soapbox.
All right, I have a question coming in from Krishna, and their question is...
This Krishna White?
That is Krishna White.
Hey, Krishna, how are you doing?
Their question is, what are the challenges of advocating on behalf of the athlete at the pro level when other managers, coaches may want to promote a return to play?
So I think what Chris is probably getting to, or Dr. White, is the pressure you feel in making a decision that might not be aligned with the needs of the team. And so what I always try to talk about is my relationship with my players and the staffs that I work with doesn't start at the time of injury. And so the age old in the past, and some people are still like this, and some of the athletic trainers on the call might have this, where physicians just stay in the background and aren't seen, and unless there's an injury, don't want to be heard. I don't agree with that. I think I need to be part of the team. I think the day I start creating relationships with players needs to be before they get injured, because how do you build trust with somebody unless you have a relationship with them before? And so for me, it's crucial. I want to be seen. I want to be heard in good times and bad times. I don't want to be an annoyance. I don't want to be disruptive. but I want to know players. I want them to know that they have a doctor that cares about them and they see me as somebody that's part of their team. And then when they get injured, they have a relationship with me that they know that I'm somebody that they can trust. And so I think that's with the coaches as well. You know, I've always said with my wife, I need to have 7 positive interactions for every negative interaction. And so the same thing with players and coaches, that you have to find a way to create a relationship with those coaches before that one problem. I've had arguments with coaches. One of my last Major League Soccer games I covered, it was about a concussion, and there was some upsetness that we took a player out toward the end of the game, and we hugged it out after. So that's the reality of it, is that you got to create that relationship before you have the problem. If you don't, then that's when you're going to be creating a bad relationship with coaches or players.
Okay, the next, Nadine had the questions about the ACL protocol. She said she did her doctoral thesis on a meniscus repair with an ACL in a female athlete, and she did get stiff.
No, I'm not happy about it. Not happy about it, but.
All right, so the next question comes from Brian. He's asking about your return to play protocols and rehab protocols, if you have any of those available for others to access.
Yeah, if you send an email to me, I have probably about 250 to 300 different protocols that we've kind of come up over time. Want to give everybody the sense they're not just my intellectual property. My protocol started off with Dr. Andrews, changed to Union Memorial, where I had some of our physical therapists work collaboratively on changing them. And then more recently, Dr. Henney knows Todd Furman. What I've learned about my life is I'm only as good as the athletic trainers and the physical therapists I work with. And so, Todd has been very impactful in my life, and a phenomenal physical therapist that I've worked with, and many others, Julie Williams, Todd Maurer. What you'll learn about me is I know every athletic trainer and every physical therapist I try to send patients to. I know their names. And so I don't send to therapy sites, I send to people. And so a lot of them have given me impact. So I'm happy to share certain ones if people need them. Often I either have Riley or myself get back in touch. Also with Rothman Orthopedics, now that I've taken this job, they have protocols, so I'm going to be using that to merge some of our protocols in the future, because again, no ego. I don't have the best protocols. I'm always learning and trying to figure out ways we can improve them.
Okay, the next question comes from Dominic, and Dominic is asking about doing independent work outside of either that school setting or the employment setting. And because athletic trainers need physician oversight, he wanted your insight into how to develop those relationships. If you have recommendations on how to start that process in order to be able to provide those added services.
Well, one thing I've learned is that the communities you live in, you need to find out what your community is and the resources that you have available there. And so going back to the other question that was asked about, if the physician isn't giving enough support, then your radius of help might have to increase a little bit. And so, what I've learned over time, and for those that know Dr. Andrews and the Alabama kind of practice model, they'll take care of athletes all over the state. And because you don't have really sports medicine providers in multiple locations, or people that are willing to think like a sports medicine provider and have that accessibility that they need to have. And so what I usually tell people is that it's best if you have people within your community helping provide care for your athletes. And so if you're able to find those people within your community, then that's fantastic. If you can't, then you need to increase that radius to be able to find that, because your athletes deserve the best level of care. And what I found over time is I take care of athletes all over on both coasts, north, south, and athletes are willing to drive, and typically parents, if they know they're getting great level care. And so for me, how do people know that they get great level of care, hopefully from me, is because of people like everybody on this call that people that send them to me, or other people like Dr. Henny, because they know we care and we know we're willing to do more. And so I wouldn't let just the confines of your county define. I would make sure your county is stepping up and has the sports medicine providers that are willing to provide that level of care. And if they do, those are the best people to help take care of it.
Okay. And Dr. Krishna White said he is doing well. Thank you, sir. There, Jason Hickman says, great to hear from you again, Dr. Osbahr. It's been too long. Keep up the great work, and thanks for tonight's talk.
Jason, oh my gosh, that's been a long time. What's the how far does the reaches of this conference go, Michelle? That's awesome.
It's virtual. You can attend from anywhere.
Oh, that's great. Congratulations.
All right. Well, we'll go ahead and wrap it up. Thank you so much for your time. Fargo, North Dakota here, as someone just posted.
Oh, that's phenomenal. And I saw the next one. Ricky Keene is awesome. So so she's phenomenal. So that's going to be a great one. And so is Dr. Snavely.
All right. Well, thank you so much for your time. Thank you for a great presentation, and thank you to everybody who's attended.
No, thank you for having me. And I appreciate everybody listening, and always people like Dr. Henny and I are here to help support. And so if there's ever questions that come up and about providers, I'm always happy to help in any way I can to make sure you're finding the right providers, because all our athletes deserve them.